I greet you a good morning once again, and I hope we had a very restful night and we are properly prepared and refreshed for today's very exciting event. The conference has been all work and fun, you will agree with me, and we kicked it off with the grand opening ceremony on Monday, which featured the keynote address, and then we had two plenaries where we discussed the role of the healthcare students in sustainable developmental goals and getting outbreak and disaster management right. We ended the day on a very high note with the colorful cultural night. And on Tuesday, we had two more plenaries where we had an extensive discussion on infectious diseases in Africa and the burden of non-communicable diseases as well. And for the very first time in the conference, we had poster presentations by medical all over Africa. The breakout sessions also began on that day, and they have involved us physically and mentally. Yesterday, we had two more educative plenaries where we discussed breaking the silence on mental health and the way forward concerning maternal, neonatal, and child health. And also for the very first time, we had two special sessions where Dr. Pauline Basinga gave us 12 good tips on being good medical doctors, and Dr. Ibrahim Badejo inspired us to be creative, innovative, and impactful. Oh yeah, and then also we had double dose of snacks yesterday. So you agree with me that it keeps getting better every day in this conference. So Toba, what do we have today?
Michelle, today is going to be equally packed, and she asked very well if we have been very well rested. It's going to be an exciting time today. For what we have today, we're going to be having another host of plenary sessions today. I'm sure we all have our schedules with us. We'll be having plenaries today. And for the first time in this conference, we'll be having oral presentations. So all the various research abstracts from students across Africa, and the selected ones for oral presentations, we'll be having them today. Equally, for the first time, we'll be having the hackathon session. The rest of hackathon presentations will be happening today as well. Please sit back, relax. Today is going to be quite exciting. Are we excited to have ourselves here today?
Okay, and without further ado, we'll be starting with the first plenary session for today, which is the 7th plenary session for the conference. And to moderate this session is practicing dental surgeon with an interest in public. Okay, to moderate this session is a practicing dental surgeon with an interest in public health, who has multiple awards to his name and certifications in various fields from the School of Global Health, University of Washington, United States of America. He's a professional photographer, a chef, and a writer in his spare time. Please join me in welcoming the versatile Dr. Okpe Okunbo.
Let's keep the applause going, Dr. Okpe Okunbo. To all those who know him, a very popular chef, Mulligan.
Good morning. I'm welcoming you guys to the first plenary session for today. We're going to be discussing the social determinants of health, and I'm going to be introducing the panelists. First is Her Excellency Mrs. Toyin Saraki, founder and president of the Wellbeing Foundation Africa. She's the founder president of the Wellbeing Foundation Africa. Ms. Toyin Ojora Saraki is a Nigerian advocate for women and children's health and empowerment, with 2 decades of advocacy covering reproductive, maternal, newborn, child and adolescent health, ending gender-based discrimination and violence, and improving education, socio-economic empowerment, and community livelihood in sub-Saharan Africa. Ms. Saraki is the inaugural Global Goodwill Ambassador for the International Confederation of Midwives Special Advisor to the Independent Advisory Group of the World Health Organization Regional Office for Africa, and she was also named as the UHC Global Champion, and is also the Save the Children Newborn Health Champion for Nigeria. And she's also a global champion for the White Ribbon Alliance for Stable Motherhood. She's also the wife of the President of the Senate of the Federal Republic of Nigeria. Mrs. Tony Saraki is not available today, but she is going to be ably represented by Dr. Famsa. Please, a round of applause. Also, one of our panelists is also Professor Eme Owaje. She's a public health physician by training and has been working as a lecturer in the Department of Community Medicine, University of Ibadan since 1998. She's also an honorary consultant to University College Hospital, Ibadan. Her area of specialization is rehabilitative and social medicine, which focuses on the need of disadvantaged populations such as orphans and vulnerable children, the elderly and urban slum residents. As a researcher, she has participated in several collaborative health-related research projects with other researchers in the United States, United Kingdom, and other African countries, and also in Nigeria. She also possesses excellent interpersonal and leadership skills. She's currently the head of the Department of Community Medicine, Faculty of Public Health, University of Ibadan. So I want us to give a round of applause as we welcome Professor Eme Owaje. Our last speaker is Dr. Adana Chukwuma, but I'm just going to read her profile, but she's not here with us. Dr. Adana Chukwuma is an health economist at the World Bank Group. Adana Chukwuma is a health economist at the World Bank Group, where she leads the health team in Armenia and supports the design, implementation, and evaluation of projects in Tajikistan, Sri Lanka, Sierra Leone, and India. She was awarded the Bachelor of Medicine, Bachelor of Surgery by the University of Nigeria, Nsukka, and she had a Master's of Science in Global Health in the University of Oxford, and also a doctorate degree in Science in Health System and Economics by Harvard University. Unfortunately, Dr. Adana will not be here today, but we are going to do very well with our two panelists that we have here. So we are going to be talking about the social determinants of health. And these are I'm going to introduce before the keynote speaker comes up. What causes heart diseases? To some, the clear answer will be blocked arteries. Perhaps it is the unhealthy food and drinks consumed, sedentary lifestyles, and lack of exercise, or their stress level. And what in turn makes people stressed, what shapes their opportunity to be active, and determine their choices about what they eat and drink. The answer lies in the circumstances in which people are born, grow, live, work, and age. These are the social determinants of health. This can enable individuals and society to flourish or not. These are the causes of the causes of the causes. If we treat patients in the hospital and we also send them back to the conditions that made them sick in the first place, have we actually made the cycle? The social determinants of health and the solution, that's what we are going to be discussing this morning. I'm going to invite Dr. Famsa for the keynote address.
Good morning, all distinguished delegates. It's a pleasure to be amongst you this morning. Thank you so much for coming out so early. So today I'm going to be speaking about connecting the dots of social determinants of health, the opportunity that is now. So as some of us already know, most of us probably already know, right? Social determinants of health are those conditions in which people are born, grow, live, work, and age, right? So whether you were born in an environment where the healthcare worker didn't have enough water, didn't have running water to wash her hands or whatever, or whether you were born where the infection prevention and control was very, very at optimal levels. These are the kind of things we're talking about. And whether people live in an area that is polluted with a lot of particles in the air or not, these are the kind of issues we're talking about, right? Most of them are actually affected by the issue of money, power, and resources. And this we all know, okay? Where there's money, there'll probably be more infrastructure, there'll probably be more resources. Where there's power and influence, there's probably more optimal outcomes, most likely, right? Now, so urbanization, health systems, social exclusion, employment conditions, women and gender equity, globalization, these are some of the social determinants of health. And poverty and income levels kind of run through most of that. In some parts of Nigeria, some parts of Africa, right, some women are not allowed to openly go and access contraception, for example. That is a social determinant of health because it affects whether they will be able to have optimal reproductive health outcomes. Globalization, someone can wake up on a Thursday morning like this in Lagos and fly to London and it's still Thursday. And then connect to New York, still Thursday because of the time difference. And we know how Ebola came here, right? So these are important issues and I'm happy that I'm privileged to have the opportunity to discuss this with you. What I'll be doing with this presentation is mainly to stir up a conversation, right? So, it's not coming to tell you what your determinants of health is, but tell us how we can talk about it. We're going to be having a panel, and we hope to hear a lot from the floor, please. So there's several accounts in the literature about what social determinants of health are and how to address them, right? But what we're talking about today again is the opportunity that exists now. The opportunities in the present. Africa has the youngest population in the world. We all know that, okay? Well over 200 million people aged between 15 and 24 years old. That's an opportunity that is existing now. We have also leapfrogged technological innovation in a generation. And what that means is, in the 70s, in the 60s, in the 80s, only people who had a level of income, could have a wired telephone in their houses, in the days of Nitel. What would naturally expect that, okay, before the mobile phones come in, at least the price of that or the cost of that should have dropped so low that everybody has a wired telephone in their houses. Then everybody can now have mobile. But no, Africa leapfrogged a technological innovation in that a few people who could afford it were able to have wired telephones in their homes. And just before everybody could have wired telephones, GSM came and everybody had mobile. So we jumped that. Now that is just an example from the ICT. It has happened in health as well. We are leapfrogging innovations in less than 20 years, 15 years, 30 years. That is an opportunity we need to use to move the needle regarding social determinants of health. We spoke about this yesterday, so I won't talk too much about it. We know Sub-Saharan Africa has the highest rate of maternal and newborn deaths, unfortunately. And then our structural levels of epidemic preparedness, it's not the strongest in the world, obviously. We're still trying to contain Ebola, we're still trying to contain some Lassa fever, meningitis. We hope that in the next 10 months, we can say we are polio-free in Nigeria. We're still pushing towards that. So I'm going to give a quick summary of the Wellbeing Foundation Africa. A few anecdotes of how we've tried to think, with the mentality of social determinants of health. We're an NGO founded in 2004, with offices in Abuja, in Lagos, and in Kwara State. We also have presence in Ghana and in the UK. Two main areas of our work. So the entire sexual, reproductive, maternal, newborn, child, and adult health and nutrition continuum of care on one end, and then elimination of all forms of gender-based discrimination, abuse, neglect, violence on the other end. In between that, there's a lot of philanthropy. We are members of the Global Philanthropy Forum. As a matter of fact, in 2014, we co-founded the Africa Philanthropy Forum in California.
We think that it is important to complement a lot of our work with philanthropy. We are happy to be addressed as a philanthropy organization when we are asked to come to speak at events or attend meetings or conferences. We believe in the power of financial inclusion. We have a program called Birth Preparedness Savings Scheme that we're about to launch soon with the financial services partner here in Nigeria. We believe in the power of impact investment. We're happy with the private sector coming into the health sector to say, okay, look, government might not be providing this in sufficient quantities or at the right time. We are private sector, we'll provide it, we'll make a little margin here and there, but we're happy to support those kinds of innovations. And then our approach are on 3 levels. So there's the global, national, state levels where we do strategic policy advisory, partnerships, stakeholder engagement, etc. We believe it's not enough to have doctors and midwives and nurses and pharmacists in healthcare facilities and people don't know that they are there. Or to have them there and the government don't think, oh, we need to actually increase their salaries, increase their incentives and make work better. So we ensure that we engage with these people. Very, very, very important. At facility level, we have programs that do healthcare provision through our midwives, capacity building, etc. At the community level, we do community and social mobilization. Social determinants of health, we must go to the community level. We cannot talk about social determinants of health without being in the community. And in the community, I was very recently in something from the London School. 5-6 years ago, people were talking about, financial access, geographic access. Or something in the London School recently taught us is, there's a third component of access, which is acceptability, acceptance. If people have it, it's close to them, it's affordable to them, but their culture feels that it's not right to procure care at that level, they will not get it. So acceptability is important. These are some of the things that are important for social determinants of health. We are talking about social determinants of health. I'll give you a brief rundown of our programs. There's an infant and young child feeding project we have, funded by the Gates Foundation through FHI 360. We also have the improving quality and availability of maternal and newborn care in Kwara State. I spoke about this, funded by our friends Johnson & Johnson, and co-implemented with the Liverpool School of Tropical Medicine. We also have the Mama Care antenatal and postnatal program, which I spoke about yesterday. Essentially, our midwives going to healthcare facilities and leading antenatal classes and postnatal classes. Very nice. We do home visits, we do community visits. We've had town hall meetings. We try to make it. They're qualified midwives. They're super qualified, licensed. We'll try to make it not as formal as the patient experience in the healthcare facility so that they can easily open up to us. We believe that we don't want them to have that barrier. And then we have the Maternal Monday social media campaign. I spoke about this. On Monday, if you go on Twitter or Instagram or everywhere and you just type #Maternal Monday, you see lots of messages from people trying to promote maternal health. We believe it's not just important to talk to doctors or healthcare professionals. If we cannot take maternal health to social media and popular media, then we're not thinking about social determinants of health when we're planning. So we know the dots, right? We know the dots in social determinants of health. But how do we connect them? And how do we connect them now? Again, this is a conversation starter, right? We can discuss this later. But there's some opportunities I just wanted to just highlight. Economic factors. We know that fighting poverty is hard. We know how much the World Bank does to end poverty. We know what the United Nations, what they do every time. We know it's not easy, but we also have some pockets of excellence. We've seen China lift several hundreds of millions of people out of poverty. We've seen Malaysia. We've seen the Asian tigers. We've seen these things. So yes, success is possible. Poverty is bad for health, but success is possible. Now, the opportunities in the demographic dividend approach. If we reduce total fertility rates and families are having smaller children, smaller dependent members, there could be this bulge in the middle of the population pyramid. And it's been shown that if that is if that company's investment in education, health, etc., then people can be lifted out of poverty. That's the demographic dividend, and family planning is central to this. Social determinants of wealth are important. That is why it's important to talk about this. Now, liberalization of markets. Sometimes it's hard, regulatory processes are slow, but we found out that where the government, sometimes slowly withdraws from providing everything and allows private sector to come in, prices come down in some places. This can improve people's livelihoods in a general sense. And if their livelihoods are improved in a general sense, it can lead to improved health outcomes. Factors of policy and politics. Now, we know that there's rarely any perfect predictor. It's hard to say if a gentleman comes to you in a tie and says, "Oh, vote for me, I'm going to be your governor, and I'll do this and this and that." It's hard to have a predictor that will say this will lead to success. It's not every politician that does what they say they will do before elections, and it's not every policy document that we can study and do all the econometric analysis and whatever and say this is the policy document that will solve the HIV/AIDS scourge in Nigeria. There's this field of implementation science. It's not every time that we have the best policies and it will lead to the best results, right? So, but there are opportunities in community and social mobilization, right? There's an organization called White Ribbon Alliance. The White Ribbon Alliance for Safe Motherhood is headquartered in DC, Washington DC, but they have a liaison office in London, and they have offices across the world, including Nigeria. In Nigeria, the White Ribbon Alliance Nigeria, there's something they are doing called citizen-led accountability for maternal and newborn health. What that involves is they go to communities, they talk to them and say, they have focus group discussions. What are your problems? Why do you think women and newborns are dying? And women open up, fathers open up, traditional rulers and religious leaders open up. And then they appointed citizen journalists. Citizen journalists are not spies, they are not SSS, they are not CIA. They are supposed to go to healthcare facilities. They are journalists, citizen journalists. They call them CJs. Learn experiences from people who feel they have had the best of care and report them to the White Ribbon Alliance, which has a coordinating body of stakeholders. And they take those complaints directly to the governor's office. That is an important mechanism of community and social mobilization to improve maternal and newborn health, for example. And there's also voter awareness and participation. We know about the European Union. They're very keen on ensuring that there's democratization of processes. So if voters are aware that they should get their PVCs, if voters are aware that this politician is having this policy that can promote my health, and those voters come out on the day of election and they vote, perhaps, again, this is open to discussion, this is open to debate, perhaps we can get the right leaders into power. Perhaps the right leaders that will do the right work, right? And then public-private partnerships. Governments cannot do everything by themselves. We have hospitals here in Nigeria that some of them lease out their laboratories to the private sector. These things are part of it. And then social-cultural barriers. Now, it could take several forms, including harmful traditional practices. We know about female genital mutilation and cutting. We know about forced early and child marriage. If we don't analyze the social determinants of health around these issues, we can't make progress just by drafting policies, appointing a program officer, saying this is your budget for 2 years, you're going to do this, do that, do that. If we don't think about the social determinants of health, we won't make progress. And also, so there are opportunities in the technological mobile revolution for awareness creation, right? People can sit down in a village anywhere in Nigeria and just get a message on their phone, sometimes even in their local languages, and they can, some of them are voice notes actually, they can listen to this. And then also, we are seeing an increased engagement of our traditional and religious leaders. They are coming out more than they used to come out. They're talking about polio, they're trying to eradicate myths, polio vaccine might cause this and that. They're coming out and saying, no, we need this. That is an opportunity in the now that we need to leverage on. Right? And then of course Africa's teeming young population. We can't overflow that. So in conclusion, the social determinants of health should be enshrined in the health in all policies mantra by governments and leaders, including the private sector around the world. Now the health in all policies essentially means If a minister of works and housing, for example, who is trying to build the bridge, right? When the contractors come, Julius Berger, whatever they come, they should have either a doctor or a health person in the room that analyzes the health effects of that bridge, right? The same should happen in the Ministry of Agriculture. Every time policies are being developed in the Ministry of Health and outside the Ministry of Health, there should be that health in all policies. What are the health effects of these things that we're starting? Yes, it's Ministry of Agriculture and Rural Development. Yes, it's Ministry of Women Affairs and Social Development. But what are the health implications? Until we enshrine the health in all policies in our policy making, in our policy debates, we would be addressing social determinants of health that we will need to do to improve health outcomes. So we should always remember that an opportunity untapped can be a worsening problem in the near future. We know this from medicine. Sometimes when the patient comes to you and they're not as bad as when they get worse the slower you are. If you don't, the patient will not be as good as when they just arrived. So Africa has an opportunity that is in the now to address our social determinants of health. I hope and I pray that we can work to address them. But what that last point is trying to say is, if we don't do it now, it gets worse by the year, it gets worse by the month, it gets worse by the day. Thank you very much.
Thank you very much, Dr. Pasen. Before we start the panel session, we want you guys to watch a video, a 2-minute video on social determinants of health.
The difference between the rich and the poor is becoming more extreme, and as income inequality widens the wealth gap in many nations, education, health, and social mobility are all threatened. Several social factors shape an individual's opportunity to access quality healthcare. There is ample evidence that factors such as employment, occupation, education, and income influence health outcomes. This is reflected in the link between socioeconomic status and several diseases, such as heart disease, obstructive lung disease, and even mental conditions. A systematic review of 43 studies done in 14 countries across sub-Saharan Africa found that cash transfers can be effective in tackling the structural determinants of health. There was an observable impact on nutrition, psychosocial health, and the practice of risky sexual behaviors among adolescents. Social inequality is the reality we face in Africa. What we want is equality in access to healthcare come 2030. How do we reconcile the two? How do we achieve universal health coverage in light of our current plight? In this panel, we will stimulate discussions on ways of reducing the inequalities in accessing healthcare in Africa. Enjoy the session.
The interactive session properly. I want to set up some rules. The interactive session will go on for about, let's say, 30 minutes. Each of the panelists you can ask each other questions, and I want it to be as interactive as possible. And also, we'll give room to questions from the audience after. So we'll start now. Over the past few days in this conference, everybody have been hearing about a lot of health problems, mental illness, maternal mortality, infant mortality, stress, and everything. Everything that we've been discussing about is actually coming all together under this particular topic. And how I saw this is that every sector in a country, both ICT, agriculture, works and transportation, employment, everything has to be tended towards a positive light because everything affects health. If there's bad roads, it will increase stress level for people that are going through it. If there's no employment or there's unemployment, like currently in Nigeria, a lot of young people are unemployed, despite the fact that they have education and they have despite the fact that most of them went to school, they have degrees, but people are not getting the right jobs. People are working below the minimum wage. Currently in Nigeria, there has been a lot of debate about minimum wage. I know that. And these are factors that will help improve health, either directly or indirectly. Ma'am, you work at the community level, especially social rehabilitation. What are the factors that you think can help people, especially people that live in the urban slums? And these are the people that are more prone to a lot of habits like smoking, alcohol, and a lot of other factors. How can we move on with this?
Okay, thank you very much, Ope. I think basically, as been mentioned by the first speaker, it's trying to break down the walls that exist in terms of people think I'm in health, I'm in medicine, I'm in a particular field, and the other areas don't affect health. It's good to see within the social determinants of health framework that everything falls into, affects the other. The World Bank has begun to see health as important for economic development. And economic development also affects health. So we can't stay in a corner and say, I'm a medical doctor, I don't know anything about economics. Because the economics of the nation and the growth, the GDP, the HDI, Human Development Index, they all affect health. And yes, you talked about people living in slums, that yes, maybe they're more likely to smoke and drink. I think you have to rethink that statement, because even in Ibadan, if you go across the roads in the evenings, you see that then a lot of clubs have started coming up, and those people are not poor people. They're not poor people at all. So they leave their bankers or civil servants, they leave their workplaces and they go to the clubs, they're drinking, they're smoking. So you have the middle class people that are also having some of these problems as well. In the slums or the disadvantaged areas, there's a tendency for us as health workers or people from, higher social classes to think these people cannot solve their problems. In solving the problems, we must engage with the people in the community. One of the things that I noted down is that of the opportunities, as he mentioned, is that we have a young, vibrant population that are extremely intelligent in most African countries. And we've seen initiatives, innovations that have come up. There's a young man that developed something from solar using some technology that was really cheap. How can we, use this opportunity of a large young population to begin to solve the problems of our nation or other various nations in Africa? We have this tendency of looking at the international partners to solve our problems. But really, we Africans, we understand our problems, and we are able to get community access into these communities to solve our problems. There's so much dependence. Sometimes you get to this central part of the government and they're saying the partners have not done this, the partners have not done this. Globally, there's a recession. How long are we going to continue to depend on the international partners? We have more than enough money and resources in most of our countries. I was in Sierra Leone recently and it was so pathetic. Sierra Leone has large deposits of diamonds and bauxite. Meanwhile, they're very poor. The level of poverty in Sierra Leone is amazing. Why? Because the resources are badly managed. Yes, we talk about getting a PVC. After voting the people in, I think that's part of, breaking the lines between our various sectors and saying governance is a critical part. How long will we be drained in African countries? And when we have the resources, we go across our country and we know that we have resources. And part of it, some of the initiatives involve the government training people within the communities that will come and help the communities. I'll give an example. It might not necessarily be an urban slum. In one of the northern states, I hear that it's through a DFID program, they are training women from the communities to go back to be the midwives and the nurses in their communities. Of course, the people will be more likely to accept those women. And what they have done is that they've partnered with the government to renovate the schools of health technology, schools of midwifery and nursing. And then they have also provided nurseries and provided accommodation where those women can take their children along, and they go through the program, and then there's a bond that they sign that they must go back to their communities and work. Of course, this improves the number of healthcare workers that you have in that environment, and would ultimately reduce the numbers of maternal mortality. So we need to look at our environments, and that's why this kind of conference is excellent, because medical doctors, medical students are here. You're going to be the doctors. You're going to be in charge of various aspects of health in your own nations. Start thinking, what is my part of this problem? How am I going to solve it? It's always easy to pass the buck, pass it to the next person, pass it to the next person. But what can we do in our own areas, in our own countries? For each of us, our countries need us, not to get trained and run out of the country because things are not good, but to be the change in our own countries. Thank you.
Well, thank you very much, Ma, for your contribution. I also want you to talk about a particular. You mentioned something earlier about clause springing up everywhere in urban areas. I know, and most of the time when you ask middle income earners, like, why do you go to club after work? Most of them point out to, like, oh, I'm stressed from work. I just need somewhere to unwind, somewhere to relax, and all that. I want us to talk about work in particular. For example, like some weeks ago, there was a doctor in UBTH, a senior registrar, that died after having 4 back-to-back surgeries. And there was also a report in lawsuit about a nurse that also died, that also collapsed after having a 24-hour shift. There's a lot of stress on a lot of workers, especially in medicine, in banking sectors, and in ICT. How can we combat this? And currently there's a brain drain, especially in the health sector. A lot of doctors, a lot of nurses, a lot of pharmacists want to leave the country because, not necessarily because of whatever they are going to do, maybe income, but also because of the kind of stress that is on them. How can we combat this?
There are many questions. Stress and going to decompensate in clubs. Well, I think it's a social culture that has developed over time and people feel that they can relax. But I think it's back to thinking of our problems in silos, because for me, I wonder, okay, these men, mostly, some women, they're there spending money that they could use for their families. And that affects the children, the next generation. The next generation doesn't get to see the fathers, and coming home at 11, probably to a spouse that will also be yelling at you, increases the stress. So what can we do? Behavioral change modification, what can we do as health workers? How can we educate people? Because that necessarily might not be the end of the stress, because you're spending money on a consistent basis, and shortage of funds increases the stress. I think part of it also is looking at occupational health and setting standards, national standards, and within our various countries, in terms of work hours and even within our medical circles. Because how would somebody stand for 24 hours? That is unethical. Why wasn't there a supervisor or somebody else that could tell that person, stop working? I think for the most of us doctors are A-type personalities. We are driven, we think we can conquer every mountain. But then also looking at things like regular checkups for doctors, because there might have been underlying things, cardiovascular conditions. But even if the person was a regular person without any problem, why would the system allow somebody to do 3 back surgeries back to back? It doesn't make sense. And making nurses run on shifts. These are some of the things that our associations should address. Rather than just, okay, yes, salaries are important, but looking at work conditions, and even the social environment. How do we treat the junior doctors? How do the consultants, keep on backing up work for the junior doctors? So these are things that maybe from the communique here that can go out, and in the various institutions that are represented, we can begin to have these discussions. Take this to ARDs, the Association of Resident Doctors in various institutions. I've heard of it about house officers too that are told, just go and do whatever you need to do. I don't care how you do it, make sure that it gets done. That's a form of abuse. Because the house officer at that level is supposed to be trained. And you can't back up the problems of the system. The house officer is now the attendant that takes blood samples to the lab and follows up those blood samples and comes back to make sure that everything is prepared for surgery. That's an unnecessary burden. So let us begin to have these conversations. I hope out of this conference there'll be a communique that will go out and we'll select some key items and say, Minister of Health, Ministry of Health, this is what we came up with. Some people might say nothing might be done, but at least when you start making noise, over time the noise will increase and people will know that you're serious. And I think stress is something that we all have to find ways to deal with, and clubbing is not the way to deal with it.
Dr. Famsa, would you like to also speak?
Thank you very much, ma'am. I think she has said everything. I was speaking to someone recently, and she said, look, one of the reasons why, to the work issue, one of the reasons why obstetrics and gynecology residents in the US, one of the reasons why they cut down the maximum hours of shifts they could do was because something happened, I think, in the state of New York. There was a law, and said, New York State said we have to cut it down. I think other states got into it. Yes, we need to speak to the ERDs, we need to speak to the associations, professional associations, and we should also not be afraid, like she has rightly said, to take this communique directly to the government. We should engage the government directly. In terms of people's income levels and how it affects their social lives, like she said, it's people's choices. Socialization is something that is not, you can't put in a box for a type of person. It's not, people grow and learn it from their peers, from watching media and things like that. We believe that people should work to earn a living. We believe in the power of ensuring that government provides employment to all and sundry. But as much as possible, it should be at the minimum stress levels. It shouldn't come with stress. Another thing I think I can say is government should be more active in tourism and recreation. Because tourism and recreation can also create jobs in and of itself. Because, those amusement, there was a Papa amusement park in the 80s in Lagos. I don't know if it's still there now, Those places employed people, right? People should be happy to, one of the things I don't know about other, I'm sure the WHO is here, they have a no smoking policy, right? These are new things that are coming up. If you look at some pictures of British Airways in the 60s, or even in the 50s, you're allowed to smoke on the plane. You could smoke on the plane when you serve you food and they're making your coffee, they bring you a cigarette, they light it for you in a plane. But now, we can't even think that happened, but it happened. We have pictures that show that it happened. So, people people get to know things, the more we keep talking about it. If we keep silent and say, oh, we're never going to change, people will always keep smoking on planes. We won't get to where we are now, right? There's always something about persistence. It pays off. Some people say, oh, there's so too many conferences, oh, there's so too many communications. We should stop. We can't stop. We have to keep talking to them. Government should be accountable to its people, all right? It's a service. We should, and that's one of the things that we need to talk about. When we're planning social determinants of it, we should see government as accountable to us. We shouldn't be shy or afraid to call. In the US, you call the person, you have his phone number. The person representing you in Congress, he'll be there. Just, hello, my name is Mr. Whatever. You don't need to know whether I have a job or I live in a very expensive part of town. I am calling because I live in this district of Michigan State, and this is my problem. And the person might call the call. And woe betides the congressman that doesn't speak politely. They're going to send it to Washington Post and send it to the New York Times, and before you know that person might know. That is a system. So we need people, not just doctors, not just physicians, not just nurses. We need people outside to know that they should be healthy. And health is a right. And they should always be able to talk to, not just the healthcare worker that is treating them, but the government that spending money investing in those healthcare facilities. Sir, we don't like this because our women go there and the nurses are always complaining they don't have gloves. We need to build that consciousness in our people. I think that's one of the things we need to do so we can get to where we're going to. Thank you.
Thank you very much. I want to move to one of the social determinants, one of the points in the social determinants of health, which is addiction. And in the UK, they had a policy to combat this by what the two speakers have earlier spoke about the non-smoking policy that a lot of companies are now taking up. Smoking is not allowed in public spaces and a lot. And there's also, in the UK, there's also like an increased tariff on the advertisement of alcohols, tobacco products, and also junk foods. Because when we talk about addiction doesn't have to be based on towards alcohol or towards tobacco alone. People are also addicted on junk food, on Coke, when I mean Coke, I mean Coca-Cola, on soft drink. Then people are also addicted on junk food. Some people, if they don't eat things like snacks, they snack in the middle of the night, and these are stuff that will lead to diseases, that will lead to conditions. It has been effective in these countries, but bringing it back home to Africa, how do you think that we'll be able to cut all these addiction? Because addiction most of the time is about perception. It's about what people see all the time. People have normalized alcohol drinking, tobacco smoking, unhealthy eating. How can we combat this in Africa, in African way? Because we can't usually do it like the way developed countries are doing it. So,
okay. Thank you very much. So, there's several levels to that, right? I know somebody who has a master's in addiction science, right, from the Liverpool School of Medicine. I went on to do a residency in psychiatry. Those are probably experts that can speak on the addiction side of this. But from my own background, you're talking about sin taxes, right? There's sin taxes where the government raises taxes that you pay either as a producer of these so-called sins, alcohol, tobacco, etc., and also as a consumer of this. It has worked in some countries in Europe, yes. Its applicability in Africa, of course, has to be based on the local context, right? Regulating taxes, just tax generally, is not easy. Anywhere in the world, and it's not just an African problem, all right? It's in the US, it's in the UK, it's everywhere. Collecting taxes efficiently and all that. Now, when you now want to do it with sin taxes, it's a lot more difficult. I think my suggestion is this: let African countries strengthen their tax systems first. So just basic VAT or just basic taxes that we pay, income tax, corporate income tax, blah, 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 right? If the collection mechanisms are very smooth, let's do that first. When that is perfect, then we can slowly incorporate sin taxes. I'm not saying we shouldn't, sin taxes are bad. I'm just saying it's going to be tough to measure when you don't have systems that are already standardized, that just measure efficiently. And if I feel my friend is smoking more than I'm smoking, but yet I pay more sin taxes on the tobacco, then there's a problem, right? So that's that. So for the addiction, I'll probably let my second co-panelist speak because I haven't been practicing in a while.
Okay, no, this works. Okay, thank you very much. Addiction, looking at things like alcohol, cigarette smoking has been mentioned. One of my colleagues, Dr. Debbie, is actually working on the tobacco project. And one of the things that they did a survey across the country, and they found out, observed where cigarettes were being sold. And they found out that there were some shops close to schools that you had cigarettes being sold, and they were able to take pictures and actually took it up to the level of the legislature and to the Minister of Health. And I think they're working on trying to get a ban on cigarettes being sold where children have access to. Alcohol is so widely sold, and in other countries you have an age regulation as to who can buy the alcohol, though they can fake their age. But definitely a 10-year-old cannot come and buy alcohol. And I've observed of recent, you have little sachets of alcohol, and they sell that where they sell sweets, where they sell biscuits, so everybody can go in and buy. What are the things that we can do to regulate? What can students do? Can we just do like a quick and dirty survey in the areas that are around us and see how many of the talk shops around maybe Mokola, Songo are selling this and young people have access to it? Then make some noise. Young people have energy. Make some noise about it. And other people can, at the higher level, can begin to talk about legislation. And then even in this country, there's restriction in some places as to where you can smoke. At the airports, you can't smoke at the airport, some of the restaurants. So we can begin to make some noise about these things. But when you talk about addiction, my mind also goes to tramadol, goes to codeine, marijuana. And I'm aware that there's students that use tramadol, even within this university and other universities. It's widely available. I would speak concerning Nigeria. We have such access to drugs that doesn't occur in many other places in the world. What can we do to restrict access? Young people go to the pharmacist or the chemist and ask for tramadol. They say they have pain, they have this, and it's an addictive drug. We all know about the whole codeine saga and what has happened. But we have a tendency in Nigeria, maybe some other African countries, to have a knee-jerk reflex. When something happens, then we're like, no, shut it down. What will we do alone? So I think we have to be more sensitive to our environment. Marijuana is grown in many farms in the southwest. Ekiti State apparently has a very high level of, number of young people that are dependent on marijuana. I think that can be a source of debate because in high-income countries now, marijuana has been legalized, but we all know about the side effects of it. So these are topics for discussion, for debate, and then looking at areas of what can we do to affect policy. I think that's the other thing, is that how do we take the research that we do conduct and translate it to the policymakers, make it easier, and put pressure, lobby, which is what people do in the United States and the United Kingdom, to make, for the policymakers to make laws that would be able to prevent some of these addictions that we've talked about.
Thank you, Mark. I want us to talk about, I know a lot has been said about maternal health, about infant mortality, but it's also one of the problems that we are facing generally in Africa. And I don't think that there can be like maybe a stop to the discussion about these things. Researchers have shown that mothers that are less educated, like people that just went to either uneducated or just went to primary schools alone, no university degree, they tend to have an higher maternal mortality rate. Currently is at 300 per live birth, per 100,000 live births for women. And for educated women that have university degrees, it has been seen that it's like about 150. So definitely education has something to do about maternal health. And also the kind of jobs that people do also has a direct link to infant mortality and maternal health. In the Wellbeing Foundation, you do, just like you said earlier, the Maternal Monday that has been on for a while now. So I want us to talk about how we can actually influence this through education, through demystification of a lot of that. For example, there was something that was trending on Twitter like 2 days ago about a woman that had a CS done for her. And the family of the husband were like, that means the child is not for the man because CS was done. That if the child was for the man, the woman should be able to give birth to that baby without CS. And they had to take her to a traditionalist and all that to go and swear and all that. And that shows the level of ignorance that we have in Africa. How can we combat this, especially through education?
Thank you very much. That's a question I'm very passionate about speaking about, and I'll tell you why. Now, I think education is game changing on all levels. I didn't say many levels. I didn't say a lot of levels. I said all levels. We can't overemphasize it. And when I'm talking about education, it's not only how many people have university degrees, how many people have master's degrees. There's so many Nigerian students I know right now who are doing PhDs in the US and Canada and all that, right? That's not what I'm talking about. The education that I'm talking about is this. We go to a community in Uyo, all right? We go to a community in Ondo. I'm from Ondo town, okay? We go to a community in Jeba, around Niger State. And you gather all the women together. And you teach them basic arithmetic in their local language. You teach them the most basic economics. Madam, you sell stockfish, Abi? Where do you buy your stockfish from? Okay, so this is the law of supply and demand. In their local language, in Uyo. Until we get to that level, where people that dropped out of the education, the normal formal education system, maybe from primary 6 or primary 5 or GS 2 or GS 3, and they found themselves, doing their petty business on the streets. Until we find a way to reach that Fulani woman who is 16 years old and is already a mother, and someone can teach her the basic biology of HIV in her local language. Until we get to that level, until we get development partners to come and do that, we have not started. So, I did my master's degree in Italy, right? But it was an English master's.
And one of the things that I was shocked when I got there was, I'll go into a bank. I'll say, I'm a student from the university down the road. I want to open a bank account. And the manager of the bank, the so-called manager, has a Range Rover parked outside, has 2 master's degrees, and he's meant to tell me who to go to fix my bank account. He doesn't speak a word in English. His bachelor's degree, his 2 master's degrees were in Italian. He is the bank manager of one of the biggest banks in Europe with a branch in Italy. He's educated, but he's not educated in English. And for more education. The Wellbeing Foundation is for more education, of course in English. But for those that have dropped out, the only reason why a woman who doesn't speak English or who's dropped out of the formal education system many years ago would think that her daughter-in-law because the child was not strong enough to come out through the normal route, means that her daughter-in-law has been cheating on her son. It's lack of education. And if we say, oh, they dropped out, they were in Aberdeen College for like 2 years and then they dropped out, we don't know what's happening to them. Now she sells tomatoes and we abandon them. Africa will keep grappling with these issues for a long, long time.
So yes, those that are in formal schools will teach them in English. Those that happen to drop out for any reason or the other will take education to them in every nook and cranny of Africa, in their local languages. We'll teach a woman and says, oh, I got a 5,000 naira loan from my cousin in Lagos. I started this stockfish business and now it has crashed. Now we are back into poverty. Can somebody teach her basic financial accounting in her local language? Can someone teach her why don't you see your competition? Don't you see that every person selling stockfish here? You need to, until we get to that level, we haven't addressed that basic fundamental problem of lack of education in our country. In Africa, really. That's my point.
Thank you very much. For me, education, at least the first 12 years up to the secondary school level, is a basic fundamental human right. We have to hold our governments accountable. There is no reason why, I would go back to Nigeria, the states and the local governments have security votes running into hundreds of millions. Why can't we have schools that can train our young people? Because there's just something that happens with education. I remember some time ago I heard about South Korea. When they were, after the war, when they were trying to rebuild the country, they put over 20% of their budget into health and education. Any nation that is serious about development must invest in education. What helped us in this country during at the independence was that there was so much money that was invested in education. People in the Southwest keep on talking about Awolowo. What did Awolowo do? Access to education. Yes, okay, people will say free education. I'm not somebody that would say free education because somebody has to pay. But there must be some commitment to education. We walk into our public schools, even in Ibadan, and you want to run out. We would not keep our animals. Children are kept. We must hold our governments accountable. I don't know how we're going to do it, but education is a fundamental human right. For those that have dropped out over time, yes, literacy, education, and the rest. But this is something that we must champion in this country. There are lots of people that are very intelligent. And look at our educational system, how it has gone down over the years. There are people that had standard 6 in those days. If they speak English to you, it's not the same kind of English that we speak now. They speak so much better. Why have we made education elitist? It's the private schools that take so much money. We find out that we pay more for our private schools than we pay for our public universities. There's an imbalance, and the imbalance has to be corrected. Like I said, we have to break the different silos between health and education. It's a broader sense of thought. And it's brought in economics as well. So this is something that we need to look at. Social determinants of health cover a broad range of issues, and education is a fundamental right. And then the other thing is that how do we access education? Girl-child education is very important. But we also have to see now that a lot of young men are sliding back in education. Maybe from secondary school level, they want to be movie stars, they want to be rappers, they want to be, football stars, because that's where they see that people are making money. How do we make a hard day's work an enviable thing? Not just being like Davido. So, there are social issues that we need to address, and it's a holistic address, not in parts and measures. We need to say this is where we want our country to go, or this is where we want our community to go. And it's not just the development partners. The development partners are not responsible for us. we individual Africans and African countries are responsible for the development of our countries. That's my thought.
Thank you, ma'am. Just in summary, everything we've been talking about, social determinants of wealth, the solutions to this problem comes in cadres. The first cadre, it has to do with the government. The government has a lot to do. Good policies has to be put in place for all these things to work. The community level also has to be, transportation has to be good housing, and good education, good roads. Everything has to be in proper place. Now we also have to come to the family level. A positive family environment also helps a lot. When you have people who nudges you on, people who ask after you, people you can talk to, and all that, it also reduces stress, reduces mental illness, and all that. Then we now have to come to the individual behavioral risk, which are like addictions and all that. We are now going to go to the questions from the audience. Anybody that wants to ask any question? Okay. So we're just going to take like 5 questions. So. Yeah. Professor.
I want to congratulate the panelists for the excellent discussion on the subject. So I want to basically just go back to a few basic tenets. And I'm going to be very down to earth. So we're talking about social determinants of health. So I want to ask if it's relevant to consider the fact that something as basic as water supply, sanitary disposal, in an environment we're not paying any attention to things as basic as that. Now, a lot of our children died from diarrheal diseases. There is no amount of investment that will come from external donors to fix that problem if we don't address some of those basic infrastructural needs for ourselves. So there have been vaccines developed for a lot of enteric diseases. And those vaccines have been deployed for use in several parts of Africa. But guess what? The efficacy of those vaccines in Africa is at least 50% lower than what you have in developed countries. And as far as developed countries are concerned, those vaccines have been developed, they've been deployed, they have high efficacy in developed countries, they're not going to do anything more. So we are using those vaccines, but the efficacy, it's very low. Now, I also want to, there's been a lot of discussion about the value of education. That cannot be disputed in any way. But I want to allude to the fact that the quality of education has declined substantially. You also alluded to that point. Now, there was also the comment about the doctors here, everybody should stay back and try and fix the problem. I want to give an analogy. So the analogy is real. If you happen to be in a boat, and there's a problem with that boat is going to sink. If you cannot swim, if you can swim, it's okay for you to hang on and want to save lives. If you cannot swim, I would urge you, get out of that boat as quickly as possible and go get help to save other people who are in that boat. Now, I think, I don't want to take too much time, but I think it's important that I also mention the fact that a number of the examples you gave about what's going on in developed countries. In the US, you have access to your legislators, you can hold them accountable. Yes, out in the US, I get virtually an email promoting different issues, asking questions from the state senator. I'm not asking for it, but it comes into my mailbox, perhaps because I'm a university professor out there. But I can use that avenue to hold them accountable for any problem I identify in my environment. Do we have a similar access here? For those of you who have problems, want to complain to the government and what have you, one would assume that there are ways in which you can reach out to the government and have a government that will listen and pay attention to what you're saying and make changes. If you don't have access to that, that would only increase the amount of frustration. Now, those of you complaining about stress leading to different activities and different unusual problems within the system. Again, I'm sorry I'm taking a bit of time, but it's important to put this in context. When I was a resident, and again, I'm happy to say that because I did my residency training here in Nigeria, we work very long hours. And it didn't just happen here in Nigeria. When I was doing residency in the United Kingdom, we take weekend calls. And the weekend call starts Friday morning. You go to work Friday morning, you are at work all through the weekend, you don't get back home until Monday evening. The same thing happened here, but as far as I can recall, at that point in time, people were not lining up to jump into the lagoon. People were not committing suicide the way things are happening now. So a lot has changed since then. It's very easy for people who are within the system not to appreciate this dramatic decline. People who are out and maybe come back intermittently, you can witness those changes. What I'm asking for is some more objectivity to some of these problems. The approach that is out there in developed worlds in tackling some of these problems, we haven't gotten to that point yet. And in a lot of African countries, particularly here in Nigeria, I have requested that a lot of the medical students here, if you have the opportunity, it's not everyone who's going to have the opportunity to get out of the country. Not everyone will have the opportunity to go out to Europe or the United States. But even if it is just going out to Ghana, if it is going out to Rwanda, go out there, there is a lot for you to learn. Thank you.
We're going to take all the questions and we'll respond at once. I think the next 4 people should just line up behind it so we just know that we're out.
So, good morning. My name is Osando. I'm from Ibadan. My question is, it's a question and a comment together. I was privileged recently after my final exams to be part of a research, a tobacco control research, in finding out what tobacco control is like in Africa. So at this point, I have some knowledge about how tobacco has been controlled in certain countries, like I think Uganda, Kenya. My problem is that we keep saying that we want to push research to the government so that they can formulate policies. But we do not now tend to ask if that research is also being communicated to the population, to the community that we used for that research. So throughout the panel discussion, I heard a lot of pushing the research to government, but I didn't hear any comment about it coming back to the communities. And for me, that is more important than even pushing it to government. So for example, I realized that a lot of people are not aware that shisha is tobacco. So it's prevalent because they think they are safe. So that's one. So I think in pushing that to government, we should also be able to push it to the communities. And then that ties in my question. How then are we promoting more research in our communities, and how are we involving community members to be part of this research? Thank you very much.
Okay.
From Sudan. My question is about, we keep saying that we have to stay in our countries and try to change in our countries and communities. My problem is that every one of us wants to change in this country, want to make a difference, but we also want to develop ourselves. We want to go outside our countries, be global doctors, be the best doctors. The question is how we can make a comparison between the two things.
Thank you.
Okay, we know optimal health is very important and necessary for our day-to-day activities. And as was earlier mentioned, education is a fundamental human right. So in a setting where culture, tradition, customs are so immense, in such a way that you have difficulty sensitizing the population, educating them of how to live a healthy life, and they deny because of their culture and ignorance and lack of education, what other approach can you use for us to have, like for universal health care, what other approach can we use?
Thank you.
Good morning. My name is Akina from Nigeria. We were told that, okay, from the first 12 years of education, it should be a fundamental human right. Teaching has, for a long time, been a very noble profession, but in Nigeria, the teachers that take these first 12 years, most of the time, they have no drive. They are very frustrated, and in other countries, let's say America or something, it's not like the teachers are making 6 figures, because I've not heard of any high school or elementary school teacher that's making 6 figures. So let's say in Nigeria, they are not well paid, but why we don't have that drive? Like teachers at that level, they don't even care. They just, okay, want to get their paycheck and, okay, move to the next day, because I see how they treat the students. So it's not even just infrastructure. So what can we do to encourage our teachers at these levels that are very critical? Thank you.
Good morning. My name is Rosemary from University of Plenary. I'd like to ask concerning universal health coverage, especially concerning Nigeria. We know that one of the issues is accessibility to healthcare, and I understand that the National Health Insurance Scheme has been in existence well over 10 years now, but still there's no universal health coverage. I want to know from your experience in the hospital, what is the issue? Why is there still no universal health coverage even with the National Health Insurance Scheme? And what can we do to integrate the system of maybe the United States or the United Kingdom insurance scheme to help Nigeria?
Good morning. My name is Yomi from University of Ibadan. So I understand that we are all very happy that Africa has the largest amount of young people. But I'm already foreseeing a problem, seen as the political stability in the continent is very high, and I'm wondering why we're not talking about maybe birth control and family planning, seeing as if there is too much increase in the amount of young people we have in the continent, is going to pose a problem. So what are your thoughts on family planning, and how are you looking at it like in the future? Thank you.
Okay.
Good morning. My name is Ikijofo Prudence from University of Port Harcourt, Nigeria. Okay. My question is, you made mention during the session of drugs and the implications of using drugs, using tobacco, students who use some things like tramadol and co. And we know that companies that produce these drugs, cigarette companies, these companies are big companies with multi-million dollars, and they are powerful men too. And a lot of advocacy has been going on about use of alcohol, stoppage of drugs and co. And it has been effective to some extent, but has not been very, very effective. And these students or people who use these drugs, they use them for a particular reason. So since this method of advocacy and co is not working very, very fast, why don't we try to encourage researches that will produce products that will provide similar values than eliminating something like that entirely. Like there is a particular value a student gets from using tramadol, but the side effects are very, very many. So if we encourage researches that produce similar values but discourage the side effects, won't it be effective? Like example again is students who take drugs like amphetamine because of they need a long concentration span to prepare for exams. The side effects are so many. So if we can, is it not necessary to consider researches that will encourage production of products that produce similar values like amphetamine but devoid of the side effects? That's my question. Thank you.
Thank you very much. So,
Okay, my name is Jumai from University of Ibadan, and my question is this. What can we do as individuals to cope this situation? Because, for example, now, as doctors, we know about alcohol and cigarette smoking. It's not good for us. We know the implications. But you find out that we actually do these things ourselves. People do it to like cope stress. And then in Nigeria, you see signboards like, don't smoke here. And that is where people actually go and smoke. You see, don't park here. And then you see cars lined up in front of that place. Or don't urinate here. And that's where people actually urinating. It's actually planned, if I can put it that way. So what can we do as individuals to actually cope this situation? Thank you.
Okay, thank you very much. Okay, so we're going to respond.
Okay. There were so many questions, but I was just inspired by the questions. They're very deep questions. I took down 7, so I'll just run through some of them quickly, very, very quickly. Thank you, sir. Thank you to the prof. You know, water sanitation and hygiene is becoming very important now. I think just 2 weeks ago, the government launched a new project, and we had visitors from the World Bank headquarters, Washington DC. They just do water, right? And then I'm going to India in a few weeks, and one of the things they've planned for me is, because India is just about to reach that margin where they'll crash the number of people who are performing for purification. Once India reaches that milestone, Nigeria will be the highest in the world. So that's why they came to Nigeria. So, sir, we're very keen on water sanitation and hygiene. We're working with the World Bank. I'm speaking on behalf of Global Foundation now. We're working with the World Bank and Global Water 2020. We're trying to make sure that healthcare facilities and schools have running water, right? We do trainings with the Veronica buckets and hand sanitizers and hand washes and all that. So that's for that, sir. About communicating research to the people, I think that's one of the strengths of advocacy organizations like ourselves. Breaking the hard numbers in little flyers to people that can read them, right? So yes, it's good to communicate research to government, and yes, we should communicate research to the people. But the tone has to be different, the language has to be a bit, and it has to come with some community mobilization. A lot of people are doing that very well. White People Alliance is doing that. To be honest, Global Foundation, we're doing that. Save the Children, they do that. They take this new research around pneumonia, around preterm birth, they take them to the communities across Nigeria. Okay, brilliant question from Sudan. How do we, want to be a global doctor but also want to be relevant at home? There's so many opportunities for that to happen. Usually, if you engage with platforms like Doctors Without Borders, also there's some programs that allow you to, even if you're doing your residency in the US and in the UK, you can come back home and do like an extension or a donation or whatever. But I think also there's this strong alumni network that African medical schools have abroad, and they always come back to their countries to do like free surgeries or do free malaria treatment and things like that. These are things that you can partake in. So once you are connected to your local medical school alumni association in any country you find yourself, and also just medical schools from Africa, the alumni associations anywhere you find yourself, you can always come back and give back. And also joining the WHO, I think is another way to be able to, you're out there in the WHO office in Geneva or in Brazzaville or wherever, but you're also coming back home once in a while to work in Sudan and everywhere. So that's that. Now, approaches to universal health coverage. Universal health coverage is big. It's very, very big. And I will advise everyone here, if you can go on your phones right now and type WHO UHC course, I'll advise you to take the course, please. It's an online course. It might take you about 6 weeks if you're not very busy. It might take you longer if you're busy. Take that course and you download your certificate. It's the UHC course on Health Financing Policy for Universal Health Coverage. It's by the WHO. Once you take that course, many things around why the NHIS is not working, many things around, we've signed the National Health Act, there's the Basic Healthcare Provision Fund, why is the Ministry of Health and the National Primary Health Development Agency and the NHIS, why are they not just coming to kickstart this program? Those things will be clear to you. But to answer your question, UHC is very complex. It's very, 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 very complex. It takes a lot to achieve UHC. And like Dr. Tedros will always say, it's not a destination. It's a journey. Nobody will say, oh, I have attained UHC, and they go to sleep. No. You attain UHC, and you retain yourself in UHC. It's a continuous journey. It's good to use health insurance models. It's good to use conditional cash transfers. There's so many models of UHC. Go out there and soak in the knowledge. In Nigeria, it's a complex. It's very, very complex. There's so many factors. We can't deal with all of them. Actually, the time I have for that question. Teachers aren't caring enough. The kind of person I am, and this is me now, not Wellbeing Foundation. The kind of person I am, I'm not a pessimist, and it takes a lot to get me offended. And I tend to believe people will naturally do good if everything is convenient for them. So I might not be supportive, or I might not really be convinced that teachers are in themselves not caring enough, or in themselves are bad people. I might not agree with that. What I might say is, perhaps a teacher feels, oh, I've studied so much, I'm giving so much time to these students, and look at my salary. My children are suffering. I can't pay my house rent. Of course, they're demotivated. Now, I'm not saying demotivated teachers should come to class and they're cranky and they're not teaching students well. I'm not saying that. I'm not saying that. You also want to understand where they're coming from. Some of them will spend more than their salary just to transport themselves from work to home every day. So they can't be happy. So that is a government problem. They need to solve that. The government needs to, in any country in the world, actually, not just Nigeria, we need to spend more on education. We need to make our teachers happier. There is a newspaper I saw from the US, a lady on the cover. She said, I have a master's degree, I have 16 years work experience, and I still donate blood and plasma just to stay alive. And I'm a teacher in America. It was run by the newspaper for like 2 weeks. I bought the copy, I saw it. It's in my car, right? So teachers in the US are complaining, teachers in Nigeria are complaining, teachers in Ghana are complaining. We can do better for our teachers because none of us will be yelled at our teachers. So there was a very brilliant question about why are we talking about, oh, we want to crash fertility rates, we need more contraception, and then we're also saying that young people are an opportunity. Why are we saying that? Because young people are already here, you know, the way development workers work, they work from where are we now? How do we move on? Okay, the young people are here already, okay? We want to reduce it by total fertility rate reduction and increasing contraceptive prevalence rate and all that. But they're already here. What can we do with them? If we leave them idle, yes, they'll get into social vices, they'll probably promote terrorism and all that. Cybercrime, whatever. But they are here if we use them for the right purposes. So the reason why we say young people are an opportunity is that they're here, they're already here, they're old, they're mature enough. Most of them are either already in university or have a secondary school education. They can do basic computational mathematics, they can handle phones. They need to be tapped and used. So we are where we are today. Young people are all over. Let us use them. But of course, in the next 20, 30 years, we want to try and reduce their numbers by ensuring that the mothers who are giving birth now are not having the number of pregnancies that the parents that had this 200 million people, you know, had at that time, right? And I think the last one is about big tobacco and, you know, so yes, tobacco companies have millions of dollars for advertisement and also for lobbying and all that. Now, the thing about research, or should we not promote research for alternative substances that people can use? I think it's an ethical question, and I'll probably allow my co-panelists to speak about that. Research has to have an ethical basis, and I'm sure most of us here who've done courses in research in our universities will be taught that you can't just do research without an IRB approval or an ethical review board approval. So there's the ethics of research. If somebody is getting high on tramadol, why do we think they need to get high in the first place? So it's an ethical question. It might not be totally ethical for us to say, oh, let's invest money in another drug that can make this stressed student or stressed doctor or stressed banker to feel calm like tramadol, but without the opioid side effects. It might not be ethical to do that. So that's an issue. But of course, yes, big tobacco companies have money, but we also have to keep pushing as civil society, as development practitioners to try and push back from what they have. And I think that was the last question, actually. Thank you.
Okay, thank you very much. Thank you, Professor Obaro, for that, your comments. Definitely, wash is very important. Water and hygiene, we have to get that together. And, well, it's back to our governments. And I know it was said that, how do we get to the government? Definitely it's not as easy as picking up the phone and saying, I want to call you my senator from this constituency. Nobody's going to answer you. I think we can do some lobbying through the CSOs, through the various organizations. We're nowhere near where we're supposed to be. But I think the same way that we were able to get things like oral rehydration to be something, oral tea that was and salt and sugar solution, saying it again and again, training and retraining. What can we do about open defecation? Interestingly enough, somebody sent, there's this group called The Conversation that requests for articles, short articles. And they said, oh, that Nigeria has been put as second to India on the list as having the highest burden of open defecation. And you wonder why. I think it comes back to cultural practices. How can we get toilets in our environments? Because if there are no toilets, somebody wants to use the toilet and has to go 5 kilometers, then obviously the person will use the nearest bush. Not that it's acceptable. So what can we do? And these are problems. Definitely the problems exist and there are no easy solutions. But that doesn't mean that we cannot think individually and as a group and gather ourselves together to begin to do some things. In terms of research uptake for communities, definitely that's very important. We have to disseminate the knowledge. We have to go back and give that information back. That's a responsibility that we have. Most of the funding agencies are looking at that as an integral part of research grants. I'm not saying, in terms of doctors staying in the country, there's no way I'm saying that everybody has to say no. But also, while we are here, some of us, people definitely, you have to bail out if the ship is sinking. But like as we mentioned, there are alumni associations. Alumni at the College of Medicine, University of Ibadan, I'm so proud because each year they come back and they give. And they, not just in funds, they give in training. They inspire the medical students and the dental students. And we feel very proud that our students go wherever they can go in the world. But then again, it's getting tighter and tighter. You know, trying people that have tried to go to the US for residency training, it's not as easy as it was before. People can go to the UK. But while you're waiting, rather than sitting down and complaining how bad the country is, why don't we build together? And when you go, come back, let's build together. That's basically what I'm saying. We can't all abandon ship. Some of us have to stay and build. And it's, at the end of the day, it's everybody's right or choice for what they want to do. Teachers' lack of drive. I think paying the teachers' salaries would be an important part, particularly in the public schools. Paying them a decent wage. All over the world, teachers have a problem because even in the US, they pay them 9 months of the year. During the vacation, most states do not pay them. So I think it's a problem, but it's essential that they're paid well, they're trained and they're retrained, and the environment where they work in are suitable. So I think that's back to lobbying again. Universal health coverage, I think you've covered that. You talked about family planning. I think it's something that's very important for the growing population. But for most families now, young people, they want 2 or 3 children. And nobody has to say much to them, but it's at the lower socioeconomic levels that they have a number of children, and we have to continue family planning availability and education programs. I think he has answered a number of the other questions. Somebody sent me a question directly that women, we talked about management of stress, and women are quite stressed. I think it's developing initiatives about even within the workplace, where older women can mentor younger women and help them go through the process. There's a lady I was talking to, she has triplets. And I think at that time they were under 5, and she was doing a doctoral program. And she had to go for school runs. So there was conflict. But we had a discussion and, supporting through the process, looking at different solutions. I think there are ways within the workplace and within social groups that we can mentor women, mentor young men, and help them to cope through the process. Because by the time you are balancing many responsibilities, there will definitely be stress. And taking drugs is not a way of getting rid of the stress. We have to look at other stress management strategies. In many organizations, they have training for stress management because they realize that to get the best out of their workers, they have to be able to manage the stress that they have. Thank you.
Thank you very much. In conclusion, somebody talked about tobacco companies being material, they are lobbies, they have money and all that. What I want us to take away from this discussion is that our government has a lot to do, and we also have to hold them accountable. Because for an example, you see tobacco adverts in Nigeria, and after it you see a message that young people are liable to die young, sponsored by Ministry of Health. That's like a conflict. It's like the Ministry of Health is even telling the tobacco company that, don't worry, we are supporting you, though we know that this thing is bad. So we have to take these problems straight to the government. We have to take this advocacy straight to them. And also at the individual level, we also have to cope with their problem. Addiction is not the way to cope with stress. Alcohol, tobacco, shisha, tramadol, they are not good ways to cope with stress. I want to thank our panelists for this discussion, and I want to thank the audience for this wonderful opportunity. Thank you very much.
Let's give him a round of applause. I plan to speak in French, but I don't have a really extensive vocabulary, so I'm just going to say what I know. From the panel, everything just boils down to the fact that we have to be conscious, and then we have to take deliberate actions on how the environment affects us as healthcare students, healthcare professionals, members of our community, and all the patients we come across. Don't just neglect the social history or just take it as, oh, I want to arrive at a diagnosis. We should be deliberate about our actions. Okay, I'm pleased to announce that the link for the health financing for universal health coverage costs is now available on the conference app. So just open the app, click on the organizer's announcements, and then you'd see it there. So I'll now call on Mr. Sherif to give an interpretation for our French delegates. Thank you.
Bonjour à vous tous. C'est toujours la 32e Assemblée Générale des Famsa, c'est-à-dire l'association des étudiants médicaux africains et la conférence scientifique. J'espère que nous avons apprécié le programme jusqu'à ce présent. Ce matin, nous poursuivons la 7e séance plénière sous le thème « Déterminants sociaux de la santé, relier les points ». Notre orateur, Madame Saraki, représentée par Dr Lutaking Fasheum et notre professeur Ouadji, le modérateur était Dr Okwen Okumbo. Notre orateur a commencé son exposé par donner des exemples des déterminants sociaux de la santé, notamment, premièrement, urbanisation, système de santé, exclusion sociale, conditions de travail, femmes et égalité des sexes, mondialisation et bien d'autres. Les DSS. Les DSS sont les conditions dans lesquelles les personnes naissent, grandissent, vivent, travaillent et viril. Et ces conditions sont façonnées par la répartition de l'argent, du pouvoir et des ressources. L'Afrique a la population la plus jeune du monde, avec les taux de mortalité maternelle et néonatale les plus élevés au monde entier. Et pourtant, l'un des niveaux structurels de préparation aux épidémies les plus faibles du monde. Voici le meilleur moment pour réduire les déterminants sociaux de la santé. Il a souligné le fait que nous ne pouvons pas parler des DSS sans nous rendre dans la communauté. Et il a mentionné la Fondation Wellbeing Africaine, une organisation non gouvernementale qui s'est bâtie dans cette voie. Maintenant, la question est, comment relions les points? Cela peut être fait en prenant en compte, premièrement, des facteurs économiques, tels que l'approche par la division démographique, la libération des marchés, etc. Et deuxièmement, l'obstacle socioculturel, qui inclut les pratiques traditionnelles préjudiciables, l'engagement des chefs traditionnels et religieux, et l'engagement d'actifs des jeunes. Il a conclu son exposé en déclarant que le gouvernement et les dirigeants du monde entier devraient consacrer les pouvoirs de santé au développement, en particulier dans les pays à revenus faibles et intermédiaires, au public de santé. Si nous n'agissons pas maintenant, la situation empire de jour en jour. Il y avait plusieurs questions, mais notamment c'est celle de quels facteurs peuvent aider les gens, en particulier ceux qui vivent dans les zones rurales et les taudis urbains. Notre professeur Oadji a répondu ceci. Pour résoudre ces problèmes, nous devons engager avec les membres de la communauté. La participation de la communauté est la clé pour ça. Pensons à ce que nous avons pour résoudre notre problème. Merci d'avoir écouté. À la prochaine session. Je vous remercie.
Merci beaucoup, Monsieur Mustafa Sharif. That's all the French I have for you. So, I have a couple of announcements. One of our partners, Help Mom Solutions, we're talking about them. Help Mom Solutions supports SDG 3, which is good health and well-being. And they start up plans by the year 2030. They want to reduce maternal and mortality ratio to less than 70 per 100,000 live births in Nigeria. Nigeria currently has over 5 to 7,000 maternal mortality per 100,000 live births. The major cause of maternal mortality is a lack of access to basic health care, sterile tools during delivery in remote areas. And Help Mom is championing the cause. They're bringing on birth kits to help tackle this problem. And they're providing pregnant women with the best possible care during delivery. However, before they can do this, they need help funding. And they're currently entered into a competition to help with their funding. And they'll be needing our help as delegates for this conference. We're hoping to reposition healthcare in Africa, and part of these ways is to support young entrepreneurs that are hoping to tackle some of these problems. So to vote Help Mom Solutions in their support of the SDG number 3, please cast your vote for Impact Challenge with google.com. To vote for Help Mom, please follow that link. It's bit.ly/helpmom. We'll be taking a short break. It's going to be a 10-minute break, following which the next plenary session will hold. During this short 10 minutes, we want you to, you can stand, relax, you can network with some of the delegates from across Africa, you can interact, you can make use of the various booths available, the WHO booths, the Johnson & Johnson booth, as well as the various fashion outlets that we have within this conference venue. Making announcements for when we reconvene. We'll have the second plenary session, following which we'll go for our tea breaks. Thank you very much.